Good morning. We'll go ahead and get started. Thank the State Office of Rural Health for the opportunity to be in Cordele again. We always enjoy coming down here, especially to celebrate Rural Health Day. So thank you for having us and for the very nice facilities and hospitality. So we'll go ahead and get started. This is sort of a sad way to start the meeting, but this is our first meeting, fully regular meeting without Dr. Regina Medeiros with us. As a woman really that needs no introduction, but she, as you know, passed in the recent past, and is obviously probably attending the meeting from above, looking down on us, and will critique the way that we handle things if I know Regina. But anyway, I do want to just recognize a couple of the things, or a few of the things that she's done, even though, again, she needs no introduction. She served as the commission, on the commission since 2017, was treasurer from 2019 to 25, and vice chair and started in 2025. In addition to her executive leadership roles on the commission, Dr. Medeiros has served on and led several committees, including serving as chair of the Finance Committee, vice chair of the Trauma Systems Performance Committee, commission liaison to the Trauma Center Administrator Committee, and past chair of the Georgia Committee for Trauma Excellence. And she would probably punch me for acknowledging her leadership role. She really wasn't about pomp and circumstance. If you knew Regina, just a great human being, a great worker, and really a great friend. So we're going to miss her, and obviously thank her for all of her service and for her friendship. We're certainly a better place, a better state of Georgia with our trauma healthcare because of her, because she touched so many lives. So if we could just bow our heads, I'd like a moment of silence for Regina. Thank you. Okay, if I could, Katie, whoever has control of the slides, if we move into I have just a few slides with my chairman's report on the National Rural Health Day, which again, we enjoy coming here. It's getting to be a tradition for us. So thanks to our colleagues here supporting National Rural Health Day, but certainly Rural Health Day in Georgia and the Trauma Commission. Next slide. You may not know it, but there's nearly 61 million people, or about 20% of the country, of the population that's considered rural. 86% of the country's land area is also considered rural. So this is, I guess we really are a rural country, even though it may not seem that way when you see the big cities on TV. But we have a rather large land mass that really trauma has to serve in the rural areas. Roughly 1,300 critical access hospitals and 900 other rural hospitals that support our healthcare system. So all those hospitals are very important to really tying the healthcare system together, but really specifically trauma, at least is what we're dealing with today. Next slide. There's been a big focus nationally, as well as in this state, on rural graduate medical education. Our legislators have increased funding over the last decade or so to support graduate medical education, certainly in the rural areas. You can see there are 400 plus rural training sites for medical residencies throughout the country. This is a fourfold increase since 2008. And again, this has been a big push nationally. And the reason to get training sites in rural area is because programs are 2 to 5 times more likely, or graduates are 2 to 5 times more likely to stay and practice in rural communities if they train there. And certainly, I see Dr. Register, surgeon extraordinaire in Cordele. She trained at our hospital in Macon, and I guess the big medical center. I'll say that a little bit being funny, but anyway, and did her rural rotation in Cordele, and the rest is history. So Dr. Culpepper also trained with us and did a full rotation and ended up in Cordele. So I think the numbers speak for themselves. When we can get residents, trainees in rural areas, they like the rural areas, they were treated very nicely, and that relationship starts. So I think this has been a big success. And so thank you, Dr. Register, for what you do in Cordele. Next slide, please. The State Office of Rural Health, or SOAR, is very important. You see on this slide here, it sort of pulls the national, if you can see the slide, it's at the bottom in the middle. It sort of pulls the national resources together with the state resources. It's sort of that glue, if you will, and our folks, we're blessed here in Georgia to have our SOAR. They do a great job and really pulling those things together. Next slide. So with that being said, I would like to thank our SOAR colleagues, again, for being that glue that pulls national resources together with state resources, because that makes our patients have really a lot better outcomes. So with that being said, I'll jump into just an update on some of the national issues. We just completed our annual TQIP meeting that some of you participated in. For those of you that might not be familiar with it, if there's newcomers here, the Trauma Quality Improvement Program meeting is made up of about 2,000 trauma providers across the country, 900 trauma centers, all coming together for a 3-day meeting that looks at quality and outcomes. And all our data goes into that group, is benchmarked, and we can see where we're excelling, where we have gaps, where we need to improve. So there's a lot of work that goes on at that meeting to make us better. Georgia was well represented, as we've always been, with multiple stakeholders presenting either podium presentations, moderating sessions, or presenting posters. And this year was no different. We had a very strong showing. So thanks to all y'all that participated and did the extra work to get those talks ready and posters and so on. And finally, I'd like to thank all of you all, because everybody here has a paying day job. And I know the work that you do for trauma throughout the state is many times volunteer and serving on committees. So we thank you for your service. So with that being said, I think I see we have quorum. We have one person on the phone. Is that right?
Yeah, Dr. Todd is online.
Dr. Todd. So we have quorum. So at this point, can I get a motion for approval of the minutes?
Motion to approve.
Okay, Pete first.
Second.
Second. Any discussion, corrections, concerns? Okay, all those in favor, aye.
Aye.
Any objections? Okay, so the minutes are passed. And I'll turn it over to Madam President Liz.
Good morning, everyone. And folks here just wanted me to remind you that if you see the little green circles on the ceiling, that means the mics are live. So if you're having conversations in the back of the room, it'll be picked up. The audio system is quite phenomenal here. We thank you. And thanks again for hosting us. We love that you love to have us for National Oral Health Day. And one other statistic that I thought of, Dr. Ashley, is, the American College of Surgeons talks about how of our level 3 centers, less than 25% of them actually serve rural areas. Most of them are in urbanized or suburban areas. So really, if you think about it, it's the level 4 centers who are really doing the heavy lift caring for trauma patients in our state and across the country. So if you're a level 4 and you're here, or you're a level 4 on the call, we just want you to know we appreciate you. We know that you're doing the hard work every day, and we're working on a lot of initiatives for you. And we have a lot of level 4s potentially in the pipeline, so we're really excited about that. So thank you for all you do. My report's in your packet, and in the interest of time, I'm not going to go over a lot of the items. I'm just going to hit 2 items. One is that I hope you see and out on the table is the annual report, which is like 3 times bigger this year than it normally is. It's actually got a spine on it, not a staple. So we print those for you because we can't do all of that work by ourselves, and it's all done in partnership. So please take it back to your facilities and share with them all the great work that you guys are doing as our partners, and take a look at that. We're really proud of it. And there's an electronic link on the website if you'd like to share. Take as many as you want home with you or back to your facilities with you. That's the way we highlight all of what's happening in our state. So thanks for all the work that went into that. And then the other big thing to hit on is the 2025 level 1 and level 2 readiness cost survey. So I know this was a painful lift for the ones and twos that participated in it. And we're so grateful for all of the data that you submitted. And Jessica Story, our auditor, is now in the process of validating all of that information. And I think, Dr. Ashley, we haven't had you in on the preliminary calls yet, but the preliminary data on that, the numbers are big, a lot bigger than they were first go around. I was talking with our colleagues in Tennessee about the study that they just did, and they're even bigger than their numbers, which I think were double what our numbers were. But their data did not reflect the gray book changes. This is going to be really interesting to see how that shakes out. So we should have all of that ideally packaged up and back to you by January, by the start of the legislative session. So it'll be great when that comes up. So looking forward to that. And then we do have one item for approval, and that we always do at our November meeting, and that is next year's meeting dates. If you'll take a look in your packet, it's on page 27. The February meeting is in Atlanta, actually at the Emory Conference Center, because that will be our GQIP, our combined commission GQIP meeting. And then the May meeting will be in Madison. And then August meeting, we signed the contract for Jekyll. So that'll be the combined. We're going back to the February-August schedule because that's what the GQIP group really liked. I think we competed with too many meetings when we were, and weddings and all the sort of family events when we were in the May timeframe. And then November, of course, we'll be back here to celebrate National Oral Health Day again with our colleagues. So.
All right, can we get a motion to approve the proposed meeting dates for next year?
So moved. Second.
Okay, any discussion? Okay, can we get a vote? All those in favor of the proposed dates, aye?
Aye.
Any opposed? Okay, Liz, it's set.
And then, thank you. And then lastly, just you'll want to take a peruse in your packet, and our strategic, because we did not meet in August, our strategic plans were actually due in June. So now it's after the fact, but I would love this is a living document, so certainly everyone's feedback is welcome. So, and that concludes my report.
Okay, thank you, Liz. Any questions for Liz? Okay, hearing none, we'll move into the Georgia Quality Improvement Program report. Dr. Smith.
Oh, can you come up to the podium? Sorry.
Good morning, Commission. Thank you for having me. I'm certainly here speaking with Gina Solomon as well, who's the GQIP director. I took over for Dr. Todd, who's on the call, in July, and we've created a new kind of leadership triad between myself, Gina, and then Dr. Patricia Aung-Chi. She's really handling the data analysis and our work through Arbormetrics as our data platform. Really kudos to Gina and her for building out the platform and launching it. We're now have a few options and real-time data available to the state. I think what was really interesting, we went to, and Dr. Ashley has heard this, but we went and visited Michigan's TQIP group, so the Michigan collaborative that is similar to ours, and who has helped build our collaborative. And I think what's interesting with Georgia versus Michigan is that we're so much more inclusive than they are. So we include all of our trauma centers in Georgia, levels 1, 2, 3, and 4, at all of our meetings as a part of our data platform, which is where Arbormetrics really is so critical, and allowing our level 3s and 4s to be able to look at their data. And since it's Real Trauma Day, Gina and I have been kind of talking about the outreach. We have been traveling around the state to all of our level 3s and 4s, trying to do boots on the ground to kind of see what everybody needs in terms of how we can provide quality improvement projects through this platform. A recent trip to Spalding, who has their upcoming level 4 visit in December, we were able to kind of really tease out with Arbormetrics that they're actually getting a lot of high level ISS traumas there for a level 4. And we're able to dive into length of time there, and then kind of how to drill down into those patients based on Arbormetrics, which is really unique for Georgia. Michigan doesn't, at their meetings, it's just level 1s and 2s. They don't include 3s and 4s. And so I think what we do here is unique for our state, including all of our trauma centers, because if you certainly divide the NAT line, if you divide Georgia by the NAT line, there's a lot of our 3s and 4s that are supporting our citizens of Georgia. They're doing incredible work. So, and then, I don't know, Gina, those are kind of our big 2 pilot projects, I think, in terms of other kind of mission critical, projects that GEQIP is taking on. All of our trauma centers are feeling the boomer generation. Our elderly patients across the state are increasing in the percentage of our registry patients. And we are trying to tackle that early from a state perspective. We're launching our geriatric trauma gap analysis across the state. So everyone will be getting emails on that soon if you're a trauma program manager. And we're just trying to figure out how we can share best practices across the state, where there's gaps, where we might be able to fill that, where we may come and ask the commission to help us, so that we really are getting a jump forward on the elderly trauma population that's going to continue to increase in size in the upcoming decades. So I think that's it. Is there anything, Gina, that you want to add to that?
No, I think you hit on all of it. Yes, Arbormetrics has been a continued heavy lift and a lot of work. We just launched the BTE measures on November 7th. So those went live, and very excited about that and be able to work with the centers about teasing that out. We also started sending them scorecards. We're on the second iteration of that just went out. So hopefully those will be very helpful for the centers. And we also learned with Michigan, our trip to Michigan, that they do something very similar. So we didn't know that until we visited, and we had already sent out the first iteration. So it was kind of nice to see that, we're kind of on a very similar track since they have been very successful with what they're doing.
Gina, this may not be the appropriate forum to ask this question. Obviously, the commission has spent a lot of money on Arbormetrics. Where are we at in the middle of that contract? And when that contract expires, are we planning on continuing that, or is that an offline conversation?
We are actually assessing that now. We actually have a meeting set up with them the first week of December, I believe, to begin to talk about. We are good with them through December of 2026. So we're beginning to talk about, what the cost of extending that, what that would look like. We really feel we're kind of just beginning to get to the meat of
Right.
what it would look like if we even had to build something like that ourselves. So we're diving into that.
Yeah, and if I could just, sorry, go ahead.
I was going to ask if Michigan or Pennsylvania uses Arbormetrics also.
So yes, Michigan does. What we really,
Do we know? Yeah.
I don't know that Pennsylvania
They just use the TQIP collaborative report. They don't have their own
platform. I will say, Dr. Dunn, when I joined the leadership committee, I had been hearing about Arbormetrics for many years, and I knew that how much funding and support that GTC had done to get it, and I do find it valuable. At first, I mean, I think we had a lot of conversations, but it is a data platform that's allowing us to compare our outcomes in real time, more than we get from TQIP or our national standards, and be able to also offer that for our level 3s and 4s. There really is no replacement. Now, I'm not here to convince you, but I will say it's about coding. I mean, there is some really heavy lift of getting Arbormetrics up and moving. That's just starting to happen. Years. And the coding of it is ongoing. Now, Michigan is pretty lucky. They have this incredible, huge staff and they do their own internal coding and use Arbormetrics really as like kind of a platform visualization tool. We don't have coders, so we
need to report some smart people.
Data analyst, but that's a great question. But we are.
But even Michigan said, that they couldn't begin to do what
They're doing.
Arbormetric does without a ton of people. I mean, even the VTE metric launch, I mean, I had a team with Arbormetrics that I worked with that probably consisted of 5 people of data analysts and 2 project managers, 3 other data people that that built that.
And they need coaching.
Yes, so it was a pretty incredible, project to work through.
I think what they're doing with Georgia, what they're doing with us, is the first time they've embarked on such kind of a heavy lift at Arbormetrics as well, is my guess. It feels like it at least. But we're making progress. And I just being kind of boots on the ground and going around to the level 3s and 4s and sitting down with them and showing them how to do a quality improvement project is, let's look through these parameters and showing them how to do a drill down right there is that in and of itself shows to me a lot of value. I'd like to be able to give you that data on elderly trauma as we progress through the next few years. And I'm confident we'll be able to do that.
I think I was impressed by their data quality in Michigan. They're ruthless about their data quality. And so you can actually really rely on their results, which I think is some of the weaknesses of the national data set, is that they don't have time now with it being so big to go out and do the data validation visits like they used to do. And I mean, we had one of those data validation visits in my prior life, and it was so valuable, but they just can't do that one-on-one any longer. So I think that's kind of the next frontier for us, is we have to really invest in that quality piece.
I think what we saw in Michigan is they do a data validation as a part of their performance-based payment, PBP, every year. Now that requires a big staff and a big kind of load for GQIP. But I know that Dr. Anchi and myself met on Tuesday night, and with who we have, I think that is going to be something we'd like to launch into the next 2 years, is redo our data validation and see what that cadence is going to look like. So I'm sure you guys will have some requests for you to think about that, but I think it is invaluable to make sure the data that we're analyzing and giving, and basing our improvement measures on needs to have really high quality here in the state of Georgia. Thank you.
Okay, thank you, Dr. Smith and Gina. All right, this time we'll move into the Regional Trauma Advisory Committee report. Crystal Shellnut. Crystal.
All right, good morning, everyone. It's going to be a brief update for me this morning. I wanted to discuss a recent leadership change that we've had with the RTACs. We're very happy to welcome a new Region 3 RTAC coordinator, Steve Elmgren, who works for the Grady Burns Center. He's a great asset already to Region 3 and has some really exciting ideas So we're looking forward to kind of getting him settled in that role and the things that will be happening there soon. I also wanted to, since we are in Core Deal, I wanted to introduce everybody to Ben Whitten. Ben is the RTAC coordinator for Region 8. He's been in that role for almost 6 months now. And wow, Ben had a lot of work on his plate, and he has exceeded all expectations. The amount that he's accomplished in just a short amount of time in this region is, I don't know how he works a real job too. If I should have put together the Stop the Bleed maps to show you just what has happened in Region 8. Just with that program alone, Ben's distributed 1,000 kits. He's caught up any schools that were missing. We're about to do another bus program. I mean, whatever the gaps were that were identified to Ben up front, he's really done an exceptional job. So I just wanted to acknowledge him and the amount of work that he's accomplished.
Yeah, thank you so much. It's a privilege to work for the region and then get out and improve our trauma system. Thank you.
All right, so education, the RTACs continue some great education. We had a couple of conferences recently that I wanted to highlight. The Region 2 Trauma Conference, Northeast Georgia Trauma Symposium, had more than 600 participants, a really great day of classes. And Kyle and his team do a really great job of putting that on. And we also had several months ago a Region 10 instructor and provider symposium, 2 days in Athens. Again, great training. They put together just a wonderful resource that will continue in that region. So wanted to appreciate and acknowledge their efforts as well. Performance improvement remains a top priority for all of the RTACs. Thanks to Gina and GQuip, they're now getting quarterly data reports, and we're able to focus a lot of the initiatives around injury prevention, education, kind of focused exactly on what that region needs and where we see opportunities. So we appreciate the support and the collaboration with GQuip. And that's all I have for my update, and I'm happy to take any questions about the RTACs.
Okay, I see no questions. Are you going into also the EMS education planning?
I will, and I'm going to stand up for that.
Okay, all right.
All right. Katie's got my PowerPoint. Thank you. All right. So over the last year, we created and completed the first educational needs assessment that really is driving a lot of the programs that I'm going to talk about today. To my knowledge, it's the first one that was done in Georgia. And now we have a very clear picture of what our providers need, where the gaps are, and how those gaps impacted outcomes and provider support. So what you're going to see today is the immediate and the achievable plan to modernize and stabilize the education programs offered by the Commission. It's built entirely from the data that we've been receiving from our providers, from our leaders and our hospital partners. It aligns with national trauma standards, and it's calibrated to the capacity of the team and the partners that we have right now. This plan will strengthen the entire pipeline from initial education, our instructor development, simulation, anatomy labs, mass casualty readiness, leadership training, and standardize a statewide method to measure the satisfaction from those classes, competency, and trauma knowledge. It's going to reinforce our local capacity rather than replacing it. It's going to ensure that every region has access to high quality, relevant, and consistent education. All right, and I'll start to kind of go through the different options now. All right, so when kind of looking at the project and the scope of it, I wanted to first identify how can we align strategically with the rest of the trauma system in Georgia. So first we wanted to strengthen and really have a direct pipeline between the Commission and our frontline EMS providers. We want to make sure that we continue the workforce development with initial education and growing that pipeline of new providers. We want everything that we do to be data-driven, from the GQuip data to the needs assessment and the information that we're collecting from the testing programs. We want to ensure that acknowledging that data and incorporating it into future programs remain a priority for us. We want to make sure that we're improving communication between the educators and the Commission, and then, of course, the local providers as well. And then a really important one is to demonstrate the ongoing commitment from the Commission to our EMS providers and very important role that they play as the first contact for our medical care and the impact that that's going to have on outcomes. And then, of course, advancing the trauma system and making sure that everything that we do is a collaborative effort. All right, so first, a couple of programs that we're going to implement. The first is a central location for all information and resources. On the Trauma Commission website, under our grants and programs, there's trauma education. That link is going to be kind of a sole source repository for how to find access to our programs. From students registering for courses or services requesting access to initial education, everything will be linked through that spot. So everybody has access to it all the time and knows where to go if they want to know about programs in their region or future opportunities. So we're also going to be using the Survey 123 platform. I know we've presented some of the information from that program in the past. This is one of the maps that we use to identify where our NAEMT programs had been. The way that this is going to work is that in real time, we're going to be able to watch student registration across the state. So if we identify that a course has low enrollment, we can pivot, either do some better marketing and see if we can fill the course, or maybe we identify that that wasn't the best location to place the course. But in real time, we're going to be able to see where our students come from. So this is going to capture data at the point of instruction, right? So when students register, we know that we start to have validated data points right then. We don't have to worry about fixing data on the back end or ensuring that we've established communication through the students. We'll make sure that every point is validated as it goes in. I'm really excited about the opportunity to use the geographic mapping and overlay that with some of the other things that we've discussed. The MedEd Prep testing software, we'll be able to overlay that and see where we have knowledge gaps across the state. So again, we can pivot and refocus education specifically to where it's needed. And then the data-driven improvement, of course. You can go on to the next one, Katie. Thank you. So MedEd Prep is a program I know I've discussed with the commission in the past. Last year, we implemented this as a required component for all of our initial education programs. So if you did a grant-funded program, students participated in the 5 module exams and the 1 final exam, and that allowed us to see across programs, regions, and the state where our knowledge gaps were. And my recommendation is that we implement that for our continuing education programs as well. There's an opportunity for not only post-course testing that we can identify what were the learning outcomes of this program and did we meet them? That's an accountability metric that's really important, but also where do gaps still exist? I know you can't read what's on this one. This is a slide that I presented to you guys several months ago, but this is information that we got from an EMT program. And unfortunately, if you look at the lowest points on the bar graph, it was mass casualty, it was chest trauma, and assessment questions. That's really important information for educators to know, is where are our gaps? So how can we feed that back into the system? You know, information like this tells us the types of things that we can do to support not only our educators and maybe where their knowledge gaps are or additional resources that they need, but also can we pour into the providers that are now licensed in that community and with what content? All right, so the first kind of group of programs I'm going to talk about are initial education programs. What a critical resource this is for our partners across the state. It's a lifeline for many creating their next workforce. And so I wanted to show you the numbers from the previous programs that were grant funded over the last several years from the commission. As you can see, that program was increasing. People are increasingly reliant on that as a resource to help drive their workforce. So 3 different programs that are going to be under our initial education grants. The first is our EMR programs. So these are our community first responder programs. Maybe local fire departments or rural communities is typically where this was targeted. So our first responder course and what the requirements of that will be listed are a 10 student minimum and then approval from the State Office of EMS and Trauma. The next one, this is the one that we have the most participants in. This is the EMT and Advanced EMT grant programs. So for this program, it'll support at least 50 programs across the state, and it sets an increase in the funding limit. So this will be a $10,000 course payment with a $2,000 performance incentive. The metrics for those will include what's the program, the total program attrition, and then national registry success. That also ensures that we get a little bit more feedback on were the students ultimately successful at the national registry. And that was something that was approved by the EMS committee last year, was so that we can measure, is the testing software working? Are we able to improve the number of people funneled into our workforce? Next one, Katie. All right, so this will be a new program and something that I'm pretty excited about. So this is a micro grant we set a 12 student minimum for the EMT and AEMT program. We know that sometimes in our rural communities, that's just not achievable. They don't have the resources either to have a class that large, or they don't have the number of interested parties. So with this grant, we would include covering textbooks, the cost of the testing software, and an instructor stipend for small programs. So between 6 and 11 students, if they weren't able to get to that 12 student minimum, first, I would like for us to partner them with a neighboring community that maybe has a similar problem, maybe combining resources of instructors and our equipment. Maybe that allows them to get to the 12 student minimum. If that doesn't work, we'd like for them to be eligible for a micro grant that would help them cover the cost of the program. All right, and because we know that this is a big change for everybody, I think us having direct lines of communication with our EMS educators and with our services that rely on these grants is going to be really important. So I'd like to do an informational session in December where I can talk about the grant requirements, how they can find the information, kind of demystify what the process is going to be, and make sure that it's streamlined and it's very easy for people to apply and get access to these grants. I'd also like to collaborate with the State Office of EMS and Trauma to ensure that the requirements for participation from their perspective are also communicated up front and very clearly to participants, and as well as MedEd Prep, that they'll understand what the requirements for testing are. And if they plan on applying for our grants, we can go ahead and get their instructors in that software and allow them to start to learn it, create practice tests or whatever it is that'll benefit their program the most. And we'd like for that to be strongly encouraged for anybody who applies. It would also be a recorded session that we could post on the website as an easily accessible kind of resource. All right, so that was our initial education program for providers. It's also really important, if we're going to create new providers, we also have to create new instructors in the state. So this program is essential in ensuring we have that pipeline and making sure that we partner clinicians up front with the people ultimately who are going to be responsible for getting them credentialed in that role. Go to the next one, please, ma'am. All right, so for this program, the State Office of EMS is going to be hosting an instructor program, at least 4 of those a year is my understanding. And my recommendation is that we support the student component of that with travel costs, with textbooks, to ensure that we have expanded access across the state, that the finances of traveling to the course are not a barrier for participation. And again, we're partnering those clinicians up early with the state office who can help them navigate that process that can be fairly lengthy by the time you get your internship done and things like that. We want to ensure that they've already made those relationships early on with who's going to make them successful. All right, so now for continuing education for our EMS providers. So it's a requirement for maintaining your license that you complete 40 hours of continuing education, and that includes a number of trauma-specific topics. So for us, it's important that that's high-quality continuing education, specifically around those low-frequency and high-risk skills. Those are also the ones that were identified very clearly across all 10 regions as being kind of pinch points for our providers in the educational needs assessment. CE is going to improve our provider competency and hopefully supports agencies in their readiness and helps to reduce their training costs as well. All right, so the first grant will be for we'll call them our canned courses. So these are typically our NAEMT courses. It's an 8-hour or 16-hour program. These would be grants that go directly to the EMS services who would be able to teach those in-house. We're also working on a repository for instructors who are already credentialed in this, so that we can connect. If you want to host a course but you don't have instructors, you'll be provided with a list so that you can find the resources to do that. All right, tactical emergency casualty care. This has been a popular course for a long time. This course kind of changes the paradigm of what we've always taught our EMS providers, which is you don't go in until the scene is completely safe. Well, research tells us that that might not be the best option for patient outcomes. So the course that we're proposing is a 2-day course. It's 30 participants. And what's really unique about this one is it's going to be regionally specific. That's an important concept, in that everything that we build is designed specifically for the areas of the state where it's taught. Responding to this type of event in Region 3 versus Region 8 is going to be a dramatically different scene with different resources and different decisions that need to be made. This program is going to allow us to kind of teach to that, and also lead the students with resources following the course. That's going to be important in all the programs that we build. We know that we're not going to be able to touch every single provider across the state with every program that we do, but we can touch every service. And if those students are able to take back resources like sample protocols or things like that, that's going to be really helpful in kind of expanding the footprint of the things that we do. All right, so the next course is an EVOC Instructor Development Scholarship. So we have had conversations with an agency who will be able to train at least 20 of new instructors annually. And as a part of this scholarship, we'll ask that everybody who participates in that, 2 per region, return to their region and put on at least 1 course. That should allow us to teach in the neighborhood of 40 students per region annually. And again, we're going back to developing those regional resources to ensure that this is sustainable. All right, really exciting new project here. So this is a partnership with Augusta University's Office of Critical Event Preparedness and Response, or CPAR. So this training is going to be, again, regionally specific in the areas that we host it. It's going to include some prerequisite work and a lot of resources for after the day of training. But we're specifically designing this course around the American College of Surgeons COT priorities around developing RMOCs. Everybody probably remembers from our last meeting in Macon, the presentation that Dr. Bolger gave us on the importance of RMOCs and the importance of starting to develop those structures early on and then be able to support that as an ongoing project. So this is really the first step in that development, is creating the statewide plan, starting to talk to our regions about early development of that and training them on it. The goal of this project and the coordination with Augusta University will be, not only are we going to do this as our initial training for the first year, but in subsequent years, we'd like to see this develop into then its regional drills with after action reports, after actions, lead into additional courses where we can really develop the system year over year. We won't offer the same course every single year. It'll evolve as our system improves. All right, so this one is for our instructors. So this is a regional EMS instructor symposium, and this is really support for that symposium that the State Office of EMS is already doing. One of the reasons why this is so important for us to continue to have engagement and involvement in is this is the opportunity for us to have some loop closure with our instructors. We've talked already about the type of data that we're going to be collecting from MedEd Prep, from Survey 123, from our educational needs assessment, but we haven't covered yet how we feed that back into the system to allow our instructors to improve. And this is really that opportunity. So it's 10 symposiums, 1 in every region. And again, we're going to be able to take that regional data that we're gathering and make sure that those instructors know the types of information that we're finding. And we can also discuss what are the Trauma Commission priorities and initiatives that we have going on at the time to, again, ensure that we've got some system-wide improvement. All right, another program I'm really excited about. So cadaver labs, of course, are a really popular program, and they're really necessary for many of our paramedic programs to get those skills required for their initial licensure. Historically, our grants have not been able to touch the technical college programs that are responsible for creating a lot of our ALS providers. So in this program, we would procure some specimens. These are, use a specialized preservation technique. That means that they're not going to be only a one-day lab. So we anticipate being able to get up to 5 days of cadaver training out of each specimen. And I've had conversations with 2 technical colleges that would like to pilot this program. And the goal is to do 3 days of cadaver lab that are open to the regions, right? So we're able to schedule time. The service can come in maybe with their training officer, their medical director, and we can have some directed lab time. There'll also be open lab time for people who kind of maybe don't fall in that category or can't get their medical director or training officer to come in. And then the last 2 days of the lab will be for our paramedic programs. So they can get all of their skills. They can do more advanced dissections and other cadaver work. And when I was a program chair in the technical college system, this is something that fell well out of my scope and ability financially. We never could have afforded to bring specimens into our college. It just wasn't something that I had the resources to do. This allows us to pour into our ALS providers while they're in this critical training phase and expands the reach of our grants to include our technical college partners as well. All right, so this is a direct result of the needs assessment and the information that we received. Simulation was overwhelmingly popular when we discussed it in the needs assessment. Unfortunately, almost across the board, when people got out of an initial education program, they no longer had access to high fidelity simulation. We recognize that that's a gap. So the goal is, how can we manage that gap starting soon? And that's a partnership with the Simulation in Motion program. This is, they're focused out of Montana. They have a large footprint in the area. And not only are they going to bring the training for 3 days in every single region, but this is also a step to developing our own program if that's something we'd like to pursue. So in addition to training the providers in the region, we're also going to have the opportunity to train up our instructor cadre moving forward, getting them access to working with the mannequins, working with credentialed providers. And that's a really exciting component. That's not a next year program, but I think that that's something that can certainly be on our horizon for a 3-year program. Additionally, we talked about our new instructors who've completed, they're working on completing their 40-hour internship. This can also serve as a portion of that internship. As a new instructor, I never would have had access to simulators or mannequins, but we can bring them in while we have professional educators. We've got a captive audience and partner them up with them. They can learn about not only the mannequins, the importance of how to deliver scenarios and simulation-based training, and then the all-important debriefing. I think anybody who's done a simulation will probably tell you they learn as much from the debriefing as they do from the simulation itself. And so that's a really important skill for us to develop in our educators. All right, and then this last program is a partnership with Fitch & Associates. They are a national leader in EMS training, specifically leadership training. So in conversations with them, they have multiple tiers of programs. The entry level for that is a program called Beyond the Streets. So this tier 1 or entry level supervisor training is developed off of that one, but again, is going to be a Georgia-specific program. So this program would be twice a year. It's a 2-day course and would host around, I think it's 35 to 40 students for each one. And it's really designed for those who are new supervisors or looking to move into a leadership role. And kind of equipping them with tools and resources. And again, the resources after as well. They'll be provided toolkits and other things that can hopefully make them successful in their role. All right, the second tier is under development, again with Fitch & Associates right now, and it's based off of their ASM, the Ambulance Service Manager course. Very popular, very well-respected program that would use the fundamentals of that and then again incorporating the specific needs of our state and the specific needs of the region. What's exciting about this one is it's not only a leadership training, but this is also a pipeline to start to bring people into leadership roles with the commission and with the RTACs. There will be coursework and a capstone project that goes along with that. And I envision something like us identifying what are some emerging threats or needs for our EMS providers and developing some programs that can be supported by the commission and implemented for our EMS partners, whether that's around Stop the Bleed or maybe introduction of new medications that are critical to trauma care. TXA comes up. That was a kind of a new one several years ago. But for us to really take what are problems right now, and as we develop our leaders, we're bringing them into the fold so that we've got a steady pipeline. All right, and Dr. Ashley, this one's for you. This is the research that I want to do related to all of these programs. So we want to track the evolution of our educational needs assessment. The amount that we learned from the first year of that has been so instrumental, not only for our RTACs, but also in supporting our initial education programs and certainly for developing this. So I'd like to see us trend that educational needs assessment and see if the things that we're doing are impacting the needs of our providers, right? We need to pivot this program every single year based on the feedback that we get from our EMS community. You know, it was always my goal when I was teaching to never teach the same program twice. There's always a way to improve it. And this really gives us the opportunity to improve year after year. So the second would be to evaluate how different training modalities are going to improve our clinical skills. We've talked about a lot of different courses and a lot of different ways to deliver education. I want to find what's effective. And I want to find what's effective for new providers and senior providers, for EMTs versus paramedics. We're going to have a lot of different types of coursework, and we're going to be tracking a lot of different metrics. And I want to start to pinpoint how we can be maximally effective with the dollars that we spend and the education that we push out. And then the last is to develop evidence-based support strategies for our initial education programs. We're already looking right now at what topics are they doing really well at, right? And what topics we need additional support of. I also want to look at how their course structure, their course design, and the resources that we give instructors, how that's impacting success kind of broadly across the program. That starts to give us a roadmap on how to take new instructors coming into our system, make sure they're maximally supported so that they can be successful. Again, my first several years as an instructor, I really feel bad for the students that I taught. I didn't know what I didn't know, and by being able to present them with best practice and resources, I think that maybe we can streamline that process a little bit so that we develop really competent educators early on. All right, so here's your recap. The courses that you see listed on the left, this would be what goes to every single region. So everybody's going to get access to simulation and cadavers and NAEMT courses, instructor training, initial education programs, and then on the right, and we're going to be implementing data-driven methods to evaluate course satisfaction. Do the students enjoy it? Because we're not going to get them to sign up for it if they don't enjoy the training. We're going to confirm that we are meeting needs that have been identified by our providers and by leaders. And then we're going to be measuring growth in clinical competencies and the students' trauma knowledge. All right. So I appreciate the opportunity to present my plan. What you've seen, I think, is the foundation for what can be a modernized, stable, statewide trauma education system. It's going to be driven by data. It's aligned with our trauma system priorities, and it's built around what the regions told us they wanted. This is phase one. So as we continue to build capacity and refine our process, we're going to expand this work into a coordinated, multi-year system that reduces variability, it increases our workforce readiness, and it improves trauma outcomes statewide. What I'm bringing you today is a responsible, operationally feasible starting point for this long-term evolution. And I'm happy to take any questions that you have.
Okay, thank you, Crystal. That was quite inclusive and a great overview. Thanks for all your hard work on that. I like the fact that you're taking the feedback from students and from the EMS providers, like what they think their gaps are, and asking the question and then trying to build a program around their needs. So learn the hard way with education. You don't always, I teach sometimes what the students don't want to know or what they already know and what I don't think they know. And so it does help when you ask the student what their needs are. And sometimes I'm surprised. So I like the pivot there. Okay, any questions for Crystal?
Mr. Chair, would you take a question from the floor, sir?
Sure.
Okay, thank you, sir. Just for y'all that don't know me, Jake Lonis, of the Vice President of Operations for Puckett EMS, part of the Priority Ambulance family, which also includes National, Central, and Ambucare. We represent a large portion of the providers, EMS providers here in the state of Georgia. We're also nationally growing as one of the largest private ambulance services. So I appreciate the presentation and the dedication to EMS. It is so critical. I appreciate the commission as well, because since its inception in 2007, I've seen significant, I've been EMS for 35 years, huge improvement in our trauma care, from the trauma grant, the training, the education, so forth. It's very welcome. However, I'm concerned. I am a voting member of MSAC, and I'm also a voting member of the Region 3 EMS Council. And it was recently reported at the Region 3 EMS Council that the Trauma Commission is no longer going to engage in any training or contract with the Georgia EMS Association. And it's concerning the way that it was presented. There was actually a letter sent to the Region 3 council members that indicated there was an email exchange between you, Dr. Ashley, and Chad Black with the Georgia EMS Association, as well as some report that Mr. Cobb presented with which appeared to be some discrepancies in the way the funds that the Georgia EMS Association was managing them. And I'm just curious as to why that decision was made. Why was that not presented to the other regions? And what Mr. Cobb, in your report, did you find that was so erroneous that the Trauma Commission voted no longer to engage with them?
So I'll answer that question as the chair. Basically, it was a business decision. The commission is responsible for making sure that trauma centers get everything that they need that we can possibly do. EMS can get everything that they need that they need. And so through multiple data points or discussions or observations, it was a business decision to move away from the new contract. We didn't terminate the contract that we currently had with GAEMS. We just voted not to renew the new contract and go a different direction. And so that's all I can say about that. It was a business decision. Our number one goal is to make sure that EMS providers have everything they need to learn, to take care of patients. And so we thought it was in the best interest to do that. And so that's where we're headed.
Yeah, and I appreciate that, Dr. Ashley. And I don't want to be that guy by any means, but everything that was presented here, for me, the Georgia EMS Association was already providing in a very great, and for me, a very beneficial way. It's like you're trying to recreate the wheel now. We had a provider that was doing all that. The EMS leadership education, that is so paramount. I am so proud to hear that you guys are incorporating that, because our up and coming EMS leaders are the next generation. And I can attest to the Fitch and Associates. I've been to their ASM class and in 2012, and it was good. I also have been to the GAEMS Association's leadership class. I've seen several of my subordinates there. It is by far superior than J. Fitch and Associates ASM class. The degree and the level of detail and, the ambulance operations they get into, J. and Fitch Associations, at least from my, perspective, doesn't get there. So again, it is certainly within the commission's right to not renew the contract. I understand the business decision, but is it the right thing to do? And I would just pose the question is why wasn't the GAEMS Association allow the opportunity to rebuke any of these so-called misfindings or misappropriation of funds that Mr. Cobb's report allegedly said or showed that he failed to provide? It just doesn't seem like that's in the fair spirit of working together.
And so I acknowledge your fair spirit and respect your opinion.
Yes, sir.
And I appreciate you coming today as a citizen and as an EMS provider to voice your opinion, because I know you're a working man and this is taking time away from your organization. So I appreciate your comments. I respect your comments, but that's all I'll be able to say about that.
Yes, sir.
In the interest of fairness to all,
Yes, sir.
I'll need to reserve my comments and move on.
Yes, sir. Thank you.
Thank you. All right. Any other comments for
Just a quick one. Crystal, are you gonna be heading on this up? Is that gonna be yours?
What now?
You're gonna be heading this up, this project, the
Yes,
whole,
sir.
the implementation once it starts?
Yes, sir.
Crystal, do we have access to enough instructors to put out all the courses you put out there?
So there are a couple of programs in which instructor development is important. The NAEMT program specifically, we can help develop new instructor groups. I think that that's something that our RTACs can help support. The benefit of this plan is that it puts us partnering with a lot of people who have those resources embedded. This is the implementation plan for the next calendar year. As it evolves, as I develop kind of these instructor groups a little bit more, then I think that there'll be the opportunity for us to support maybe a different instructor structure. But for right now, I feel like I have the instructional resources to move forward.
Okay, I see no other questions. So thank you, Crystal. We appreciate it. We'll move into the Finance and Budget Committee report with Pete Cummins.
Good morning. Thank you, Dr. Ashley. We met on the 17th of this month to go over the latest points for this meeting. We did not have a quorum, but we nevertheless went over a few items, which I think you have on your handout. I want to once again thank the group. Just a tremendous help putting all this together. I can't imagine, Katie, with your assistance putting all this. This is we're very fortunate to have all this presented in a format that's actually usable moving forward, and that's a big deal. So the first item was the 2026 budget. And essentially, you'll see that it says a small reduction in funding. Katie, do you want to address that?
Yes, do you want to go ahead and just go through this and then I can go through the packet, or do you want me to hit on each of them?
I can go over them, then you can just start if that works for you.
Okay.
The second item was the uncompensated care. Third item was the 2027 budget, which we will ask for a motion later on. Dr. Ashley, I think we'd like to possibly table the Arbormetrics financial discussion for right now, if that's okay, if you table that to the next meeting.
Okay, if your recommendation, that'd be fine.
Thank you. And then the 2026 summary of the trauma center funding. So those are our topics that we'll go over. And Katie, go ahead.
So the first item is the FY26 approved budget. You guys have already seen that, approved it. The one pager that was presented and approved is the next item in the packet on page 65. And then we move into 66, and that is the departmentalized budget. You'll see each of the departments breakdown line by line. I'm going to go through each of them, but if you have any questions, and then also the trauma center breakdown, each of the trauma centers on page 74. It shows what each of the trauma centers received in the readiness, the uncompensated care, and then registry amount. Total for each of those. And then the current FY26 expense to budget, where we are at in the first quarter, ending in September. And you'll see everything is pretty much in line, 25%. And then once you move down into the other line items, the EMS budget, those are moving along. In the next meeting, you'll see that we have rolled out the EMS equipment grant, so there will be expenses there. We're in the process of completing those as we speak. And then also there are no trauma center invoices at this time. They will invoice in January.
Katie, one question about, on page 74, the readiness reflects, this is the first year that the spread for readiness is the same percent across 1 through 3, right?
Correct.
Okay, and level 4s for readiness, we're at 50%, right?
Mm-hmm. And we'll get into the breakdown of the difference between last year and this year on that in a few slides. Starting on page 80, you will see the FY25 to FY26 comparison for overall trauma center funding. It was slightly down, not significantly. That is due to the split being the extra $4 million in FY25 went completely to trauma centers. Then FY26, we voted to do the 80-20 split for that $4 million, as well as an increase in the number of centers we are funding. We went from 31 to 34. The next slide shows a breakdown of each level and the amount funded in FY25 and FY26, the total number of funded centers from FY25 to FY26, and you'll just see a slight increase in level 1s. There's one additional level, and then level 4, one additional, and then Burns, one additional. And you'll see the note out beside registry that says actual. So that actual cost is based on the quote that's provided by the registry vendor. So the level 3s and 4s, they get whatever is on that quote. That is what is put into their contract for their registry amount.
Just to add, sorry, one little contextual note on that. The reason we do that is because the vendor changed the fee structure such that it's not, I think at one time we only had like a $2,500 stipend, but now if you're a higher volume level 4, your registry fees like $13,000 a year. It's crazy what IT fees have become. So we just get whatever we find out. We ask them for the quote to show us the quote, what the actual cost is, so that they're not losing money out of their readiness on having to pay for IT costs relative to or related to data collection.
And then a question that has come up this year is uncompensated care. There is a variance from FY25 to FY26 in some of our centers. And then just to note, uncompensated care figures are based on audited claims from 3 years prior. So FY26, those are from FY20 or calendar year 2023 audited claims. And you'll see the percentage of increase or decrease. And just note, when you see 109% increase, that seems very significant, but when you're looking at the number of audited claims, there's not as many for the children's centers as there is for the other centers. All right, and then we go into level 2s, same thing, the percentage of increase and decrease. And then the ones that are asterisk, those claims are not verified when they're brought into funding, so they will be eligible for funding 3 years after they have been. So it's coming up on their 3rd year for 27, so they will have uncompensated care then. Just a summary of the changes for FY25 to FY26 on slide 84. The overall trauma center allocation decreased by 1.5%. That's due to the 80-20 split that was applied to the $4 million, and then an increased number of centers funded by 3. The next item we will need a vote on, this is the preliminary proposed FY27 budget. So this is based on our FY26 budget. This is how we do it every year. Since we do not have the governor's report to go by, we present the one pager as the proposed budget for FY27 as a reflection of the FY26 budget. So we will need a vote on that. Do you want to do that now or at the end?
Well, Rob had to jump off because he's presenting in Arizona right now, so you don't have a quorum, you only have 5.
Okay, so we'll go back.
Why don't we'll try to circle back around and help me remember.
Okay.
Just to vote on that. Okay.
And then in August, we normally present the FY25 or the prior year closeout. So this is the FY25 budget closeout summary. You have your expense to budget, not going to go line by line on that. We only returned $58.40 of state funds in FY25. So great job on executing all the plans. And then the FY 25 closeout summary, we have the departmentalized pie charts. It just shows our overall percentage of how we spend the funds. 73% went to trauma centers, and you'll see the rest allocated. Then we have each of the departments broken out: operations, system development. If you have any questions, please feel free to ask. I'm not going to go through for the sake of time, but just let me know. Okay. So FY 25 unspent funds, $58.40. We have some remaining trust funds that are in the registry startup grant that was voted on a couple of years ago in FY 24. And then we also have trust fund interest that we have voted to retain, $792,000 of that. The next slides go into our performance-based pay summary on 103. And this is for FY 25. So it shows our percentages at risk for each of the centers: level 1s and 2s at 80, level 3s at 60, level 4s at 19%, and burns at 50. And you'll see the total number of criteria for each of the centers. So we have 19 points of criteria for 1s, 2s, and level 3s. Burns and level 4s at 12. The next few slides show the actual dollar amount that was at risk for those levels by criteria. And then the FY 25 results. So the main criteria that we had a reduction in was the level 2s for the meeting attendance. And you'll see each of the areas at the highest PVP deductions by center.
That's on page 112 if you're still.
Yes, 112, sorry.
Yeah, no, it's okay.
And then also we provide the open purchase order summary as of FY 25. The ones highlighted in teal, those will be closed this fiscal year. And then we have a couple of other projects that we're working on closing out those POs too in gray. Then the super speeder revenue is on slide 116, page 116. And you'll see the trend is following. Every year it follows about the same trend. And then on page 118, this is the dollar amount, and we're down about 2% in, at the end of October from FY 25. Not a significant amount.
We always start out pretty slow.
Yeah. And then it always seems it's when taxes come in, people tend to pay, and we'll see an increase in the next few months following that. And then we also included a slide about the with the firework revenue by year. And you'll see just an increase that has occurred, and then we've gone down just slightly in the firework revenue for FY 26. And then also included is our budget timeline across GTC, the budget, or the finance committee, and the full commission. I'd be happy to take any questions. I know I went through that quickly, but just a lot of data and information, but please feel free to reach out if you ever have any questions about the information.
Katie, I'm in agreement with Pete. This is just phenomenal. The amount of data here that you're collecting and the ability to keep up with that data on a monthly basis is phenomenal. I don't know how you sleep. This is really.
She doesn't sleep much, that's why I get
It's
text
also
messages.
useful.
Yeah, it's also useful. That's
I would like to echo that, Katie. Thank you. And that may have slipped by. It almost slipped by me, but that's why I had to ask Liz to just confirm that I was hearing it correctly. But $58, our budget is so tight that you monitor $58 back to the state coffers. I mean, I've never seen anything like that. I mean, I can't control my own checkbook. So anyway, congratulations and thank you. I just want to acknowledge you. Thank you, Pete, for your oversight.
Dr. Todd will be back on around 11:25 our time. So he'll join there's another item coming from GCTE that needs a vote. So we can continue with our reports and then circle back. He's got his packet and everything in his hotel.
All right, yeah, he's speaking in Arizona, so he's on stage. So when he gets back, he had to step away. Just keep me posted of the moving
Yep.
parts and we'll get that vote in, okay, for Katie and for Pete. Okay. All right, Pete, does that conclude your report?
Yes, sir, it does. That does conclude. Is there any questions? Happy to answer.
Okay, thank you, Pete. All right, we'll move into the level 3, level 4 trauma center committee report. Dr. Register.
Hey, good morning, everyone. Hope y'all are doing well. Thanks for traveling all the way down to Cordial. Always happy to host y'all every year. So just to give you a brief update on our level 3-4 subcommittee efforts, we're still working on creating work groups for the survey we had sent out a few months ago, kind of realigning our priorities and goals, making, our 1 year, 5 year goals for the 3-4 subcommittee. We're actually having a meeting this afternoon from 1 to 2 to kind of just continue making those efforts on the subcommittees. But I think with all the statewide surveys that have gone out through EMS and ours, rural resources, main things that we've identified is strengthening our PI programs. Again, our main goal is to not work in silos. And so what we're trying to do is help make more protocols, more standardization in our PI processes, and help just collaborate and work more together as far as PI goes in our smaller centers. The other thing too is helping create more standardized protocols for clinical care in our ERs. A lot of times, we'll get contracted ER providers, and so that's really hard to implement protocol changes when your ER doc may be working at 5 other ERs. And they're all different sizes, all different resources. So as a Georgia Trauma Commission subcommittee, we're trying to see how can we help develop maybe clinical protocols and guidelines, and how can we help then implement that in the individual centers. And then another area that we identified is obviously we always talk about transfer availability, EMS resources, and then how can we then help bring some solutions to that challenges, maybe with telehealth, teletrauma. How can we collaborate with our 1s and 2 centers so maybe we can avoid unnecessary transfers, overwhelming our EMS and our larger center resources. But the main thing that I really want to bring to the table is introduce Dr. Erica Mabes. She is the chair of the Simulation Fellowship at AU, and she is doing so much work as far as helping create simulation training programs. So if you don't mind coming up and telling us about your projects. Thank you so much.
Thank you. Thank you all. It's an honor to be here. It's been an absolute pleasure to work with the people that I've gotten to work with so far. Just a little bit of background. So I actually was a resident when Regina was trauma program manager at AU, MCG, whatever we were called. We've had 6 different names. But she really was a huge mentor and advocate for me. And as I moved into the role as an attending trauma surgeon, but also director of surgical simulation, I started doing multidisciplinary trauma simulations and really working on education. And, as I started doing some of these projects, there clearly was a need for this training. And so we actually have now started our pilot year for the Rural Interactive Trauma Simulation course. And what that is, and I think there's the PowerPoint. We can go through the PowerPoint. That's a written, if you want to see it, written in Word document. But basically what we recognize is that we need to expand rural trauma readiness. And this is a multidisciplinary approach. So we have EMS providers, RTs, RNs, APPs, physicians that are in these different rural communities, level 3, level 4 trauma centers. And honestly, it's good for all trauma centers. When I give this course and I talk to people, I was like, it's not just valuable tips and tricks for stabilization of a trauma patient for the rural communities, but really for any community. We can kind of go to the next slide. So I don't have any disclosures, but so since initiation, the Georgia Trauma Commission has funded a simulations research fellowship, and I'm the fellowship director. We've advanced rural trauma education through this RITS course. This initiative has now reached 8 hospitals already since August. It's been really exciting. Hospitals and medical centers, including surrounding counties. And then building in August, I know that we didn't have the meeting, but I did submit a very brief report of the very first session that we have that went very well. It was very well received. And as we go through the presentation, I'll give you a little bit more of an update on the actual data that we're collecting. Next slide. So just a program overview of the fellowship. So this is the very first inaugural fellow that we have. This is Zach. He's fantastic. He is integrated. Part of the fellowship is that they are integrated in development of this rural interactive trauma simulation outreach course. And the focus, like I said, is multidisciplinary trauma resuscitation and also team training. And obviously the objective is to elevate trauma readiness in rural Georgia. Next slide. So the simulation fellow actually does deliver, helps evaluate and disseminate the trauma curriculum. I'm the key faculty right now, and the fellow, we co-lead the monthly outreach sessions. It does align with the Georgia Trauma Commission mission of education, readiness, and system improvement. And early outcomes are demonstrating significant improvement in medical knowledge, in confidence levels, overall satisfaction with the course. And I think that we're going to be able to demonstrate a very scalable evidence-based design. So just a background of what the fellowship is. It's not just going out and delivering it. The fellow actually completed an entire month of a course learning about simulation, learning about pre-briefing, debriefing, simulation environments, how you teach with simulation. And then they participate in this longitudinal simulation education national curriculum course as well. And then actively engage in not only institutional trauma simulations, ICU bedside procedural simulation courses, but then obviously they're an integral part of going out and teaching this course with me. Next. And so far, just to give everyone just a background of what the course is. So there's a 2-hour interactive didactics portion. It's case-based lectures with clinical management and procedural videos that we actually go through trauma scenarios and decision-making process. And we gather data from people on medical decision-making at that point. Real-time quizzes, so it's very interactive. The participants really enjoy this. This is accompanied by a procedural skills station. So this is the simulation component in the afternoon where we actually apply all of the things that we've learned in the morning to the late morning afternoon section. Then we're also getting a lot of data and evaluation. So learner performance, we have case-based quizzes. So we have a medical knowledge. We're gaining that knowledge during that interactive session. And then at the end of the course, they have a end of course test. We also have the end of course survey where we're getting confidence levels, like what is your confidence level in specific procedures, and also overall course satisfaction. And so this is just an example of my very rudimentary videos. We have a lot of volunteers that have helped out, just residents. We're hoping to continue to build this into a very professional curriculum, but this, I think Liz and Regina were kind of like, well, if we don't start now, if we wait for it to be perfect, then we're never going to do it. So let's get going. And so we have. And so this is just an example of kind of the case-based learning videos as part of the course. And then here we're actually doing the breakouts into the small groups and the simulation, and it's very hands-on, one-on-one training. And so at the end, we want to know, okay, well, what are the strengths of the course, suggestions for improvement? How do you plan to actually apply the skills? We're going to be sending out 3- and 6-month evaluations to follow up with the different centers to see, like, how did this actually impact? So looking at the Kirkpatrick, all these different levels of implementation and education. And then we have some of the preliminary data in just a minute. So the pilot, so the fall course deliveries so far, we've had 4 deliveries. Like I said, encompassing 8 different medical centers and regions. And then the next one just shows the next 2 courses. We have 2 more courses scheduled in December, reaching out to Liberty Regional and Wynn Army Medical Center. And so this has been really exciting because we are getting a lot of traction and a lot of people are really interested in this. I am so thankful for the RTAC committees. I've been trying to attend those meetings and Crystal has been extremely helpful in putting me in contact with specific RTAC coordinators who then are able to reach out to different places and people. We have started to expand our outreach now, branching with Southwest Georgia, Northeast Georgia, is scheduling in process. Northwest Georgia outreach scheduling is in process. Dr. Smith has been extremely helpful in helping put us in contact with additional people. And so we are, just moving full throttle. We already have 4 events scheduled in the spring. One of the events is going to be at a larger medical center at Phoebe Putney. And so that's going to be kind of our first trial of a larger sim trying to gather a larger region and capture multiple areas. So that's pretty exciting too. And Brandy's is helpful in integrating that. And next slide. And overall, this is our preliminary data from our first 4 courses. So we've had 83 participants, 5% MDDO, 4% APPs, 68% RNs, 7% RTs, and 16% EMS. And we've had a lot of people with a lot of experience that have been coming to these courses. And so that's been really exciting to get their feedback on how this course is compared to other courses. Go to the next one. And so this is getting into the prelim data. So in terms of was the course appropriate for my learning, 71% strongly agreed, 28% agree. You'll see kind of across the board, almost everyone is strongly agreeing or agreeing, was it delivered efficiently? Are the instructors enthusiastic? I drink a lot of Monsters, so I think that's why that helps out. But in all seriousness, I think they really enjoy the skill stations. They're really enjoying, they have sufficient practice time at the stations. I think the nice thing about this course is we really kind of tailor it to who the people are, who the learners are. And so when I have some of the physicians in there, they may want to focus more on CRICs and emergent airways and some of the procedural things. But with nursing, we're focusing how do you set up the atrium? How can we assist them in intubating? And so we really talk to them and tailor it into how do we work together as a team and how can we support each other as a team to be able to perform these life-saving procedures on patients to then improve patient outcomes. I'll keep going. And then here, just, very brief statistical analysis on the confidence skills pre and post course. You can see all skills showed a statistically significant increase in confidence level. So that's bag valve mask, spine immobilization, airway management, chest tube placement, needle decompression. And everyone who comes through the course, they may focus a little bit more on one aspect versus another. And I think that's kind of the beauty of the course. And then here, yes, the pre and post test results. So also significant improvement in pre and post test results. It's really cool to have these conversations because as we're doing this live interactive questions, we're able to address the issues and, what is the decision making and why did we make that decision? Why is this the right decision? And so you could see people had significant improvement in their post test in terms of the numbers correct. So overall yes. Yes.
But I didn't want you to lose that slide. Can you go back to that one slide?
Yes.
Just something that caught my eye. I know the audience maybe can't see this because it's small. I can see it up here, but I'll just quote some of the numbers here. But if you look at, these are life-saving procedures such as bag valve mask, jaw thrust, but look at tube thoracostomy, needle decompression, interosseous, use of a tourniquet, pelvic binder. These numbers are going up by 20 or 25%. That's significant. A pelvic binder is very important. I see those put on wrong a lot of times. A tourniquet's life-saving. I see those put on wrong a lot of times. Interosseous, needle decompression. These are very procedures, and it's interesting to see that they jump by 20% or so after your instruction. So anyway, that just caught my eye with the numbers.
And that's the focus of the course. It's really what are life-saving procedural, and interventions to stabilize the trauma patient. And people have great questions. The participants have been extremely interactive and I've loved it far more than I initially anticipated. And it's so much that I'm actually trying to get some buy down from the medical college to give me some more support to take more time to be able to do this as well. But it's also been fantastic for the learner, for the fellow. So my fellow now, we're getting fellows and residents that are going out into the rural communities. And now he's more interested in coming back to a rural community to practice. Now he wants to be a vascular surgeon. I don't know why he doesn't want to do trauma, but that's neither here nor there. But it's really interesting because it's a very bi-directional benefit to get people into this. And I actually would love to get some of the medical students, a few students interested in trauma surgery, get them to come out with us and be able to see this. Just like they talked about Dr. Register, we have our residents at MCG that rotate with Dr. Register. And now we have a significant increase in residents that are wanting to go into rural or community general surgery because we have a focus on rural surgery track. So it's all related, but yeah, it's a great course. And the fact that, sometimes people ask me, they're like, well, would you rather me try to do this versus, not try and try and fail versus not try? And I'm like, if they have a tension pneumothorax, they're not going to make it to me. So this is a life-saving procedure. And if we can teach them the basics and tips and tricks, then it's a great opportunity for learning.
Yeah, your class, first of all, this is fantastic. So congratulations. I think you are experiencing the same thing as we have from the ICDDC course with breakdown of participants. Physician participation in these types of courses is very, very, very low. And so what we found when teaching those courses, in order to be successful, in order for the hospital to be successful, it's really important to hit on those nurses because those nurses are going to be directing that new physician in the bag. And hopefully they have a good relationship. But, and so I would encourage you to make sure that you really harp on those nurses to teach them how to navigate that sometimes tricky interaction between nurse and physician and guiding that physician in the right decision. And sometimes that can be tricky, but I would hope that that's part of the course.
And that is very much so. And that's why I tell them a lot of these nurses are far more experienced than the physicians. And then I tell my own residents, I said, these nurses know more than you. You better listen to them. And so I was like, don't you tick them off. But it is good. And we even talk about like, how can you, not in a hostile way, kind of redirect and help support in those situations. Because we've all been in the situation where it's panicky and everything, it's a horrible trauma patient, polytrauma, so many things are happening. How can you take a step back and help support them? And so those have been fun conversations too, with these groups. And sometimes we get air care people and so they have something else to bring to the table. So it's really been interesting. One of the things we've talked about, and again, this is 3-5 years, but really starting to look at the data. I know I've talked with Crystal and with Dr. Smith, can we start looking at the data for these different regions or hospitals even before we go there and say, like, how can we tailor it toward them? Would they benefit? Do they have more pediatric trauma? And we've seen, we can go to the next slide, but some of the feedback that we've gotten, they love the hands-on, it's efficient teaching, relevant to clinical training. They like the Kahoot. I think it keeps people awake, and I'm up there like doing my horse and pony show. But I think it's really important to have instructors who are up there and really engaging the audience. And then the interactive questions is very helpful to keep people awake and engaged. And then it's practical. So I think we take everything back to like, what do you have in your facility? And how does this apply to your practice? And so these are really practical things that they understand and they find value in because they understand that it's life-saving procedures. Suggestions for improvement. So I think one of the things we're running into is we've had great turnouts. So originally I thought, we might only have like 8 to 10 people or 5 people. But the communities want this. And so we're finding that the surrounding counties and EMS providers, a lot of people are attending the course. So we're having at least 20, if not 30 people attend each course. And it's just my fellow and myself, except for the last time Dr. Smith came. And so it was actually really nice to have some of these other instructors. People want more instructors so we can break into smaller stations and have even more one-on-one. That's something I really want to move forward in the future, even if it's only having 2 or 3 additional instructors, but making sure we have more instructors for each station is really good, especially when you're doing, all the airway maneuvers, airway procedures, working on chest tubes, and needle decompression. I think they really appreciate that. And the FAST exam, I think it's really great. We're going to some centers where people are like, oh, well, they don't like to use the FAST exam. And I'm like, it's such a great tool, and teaching them that. And it's really been a lot of fun to see people like, oh, wow, this isn't that bad. It's not that hard. The other thing that I think is really important, and I would like to reach out to some of the people that we have, is having additional, level 1 nurses and nurses that are able to be there. When we did our original pilot course at MCG, we did have an RN that was one of the instructors and was part of the integral or an integral part of the system. And I think that would be, obviously that has value since we have such a high number of RNs. So I would like to expand to including them. And then we see peds, OB, and the other thing I see is geriatric trauma. And so I think those are 3 areas we'd like to augment the course to also include like special populations in this. Obviously, this is a pilot. We're getting started. We're gaining momentum, keeping the momentum going. But it's been a really fantastic opportunity. And I appreciate the opportunity to be able to do it with all of you. I think, do I have another? Oh yeah, we just talked about, how do you plan to apply skills in your practice? And this is where the RNs are like, educate the ED staff, apply needle decompression earlier, knowing their roles to assist in the trauma. Academic dissemination. So the pilot just course development is going to ASE. I know you have to have, it's going to ASE. And actually, Crystal's intern has been working on looking at the actual, her EMS needs assessment, the hospital provider needs assessment, and then taking a look at the course and everything the course integrates into addressing all of those needs assessments. So that has just been done in the last month and is going, I haven't seen the data yet. I'm really excited. But I am a researcher and educator, and so I am all about scholarly activity and dissemination. I actually met with the ACS Committee on Trauma Leadership last month just to kind of go through some of the stuff that we're doing. They were really excited. Their question was, how are you going to make this sustainable? And I said, we're working on it. So we're working on it. And just, part of the discussion, so the current funding covers the fellowship only. I know we have some gaps in coordination, faculty travel, consumables, leadership time. New support will enable consistent outreach coverage and statewide reach. And we want to make sure that we ensure that the program has quality, accountability, and scalability. And this was a budget proposal. I don't necessarily have to talk about it in this forum, but I'll leave that up to you guys. But I think this is just a kind of the bare minimum to continue working for the next year, and working on additional support and things to discuss how that can work together. And like I said, I'm also working on additional support from the Medical College of Georgia, and I know we've talked to the Georgia Trauma Foundation as well. And that really is that's really the next slide's just like a fun, it has pictures. It's been really fun. We love going out to these rural communities. They'll tell us like, hey, you need to go here, or go to this apple orchard, or you have to go to this restaurant. And it's just been a great experience. And I'm really looking forward to incorporating additional learners, additional residents, additional medical students, and getting people out in the community and having these awesome experiences. So that's it for me. Do you have any questions? Oh yeah, I'm working on an instructor's manual, survey instruments, all the things, right? So it's a lot of future work going into it.
Well, thank you, Dr. Mapes. That's very exciting. Good work. And thanks for presenting this today. Thank you, Dr. Register, for bringing that forward. Any questions?
Dr. Bassi online has his hand raised.
Who?
Dr. Bassi.
Dr. Bassi, you're on.
Yes, sir. Can you hear me?
We can't hear you, Matt. We're working on it.
A whisper.
How about now? Any better?
I think they're trying to turn you up. Keep talking.
Oh boy, should I say my ABCs?
We can hear you. Just talk loud.
Okay, I'll talk a little louder. So, Dr. Mapes, awesome presentation. I have like 100 questions circulating through my mind in terms of how this could, really take off and blossom. First of all, I just want to know, where does the fellow come from? Is it a year off from your residency program, or is it a separate outside person that applies for that?
So right now, our first fellow is a resident who's in between his second and third year of general surgery residency. My kind of overarching thoughts for the fellow would be, I would love to continue having a fellow from within our residency program. That's someone that I know and I can kind of handpick. That being said, I think it is something that we would open up to other facilities, whether, I talked about giving some priority to some of our other residencies in Georgia. So like Kennestone, Grady, any other people that are interested in surgical education simulation fellowship. Just to give a little bit of background, there are only 20 accredited ACS surgical education and research simulation fellowships in the nation. So I'm trying to get accreditation for my fellowship, but that's kind of it. So there's not that many of them. So I think once we get to the point of accreditation, this could be something that nationally people are wanting to do. And especially with this added rural outreach being an integral part of it, I think it gives us an edge that really sets us aside as a national leader in surgical simulation education.
Awesome. My only other question, well, at least in this forum, is Dr. Dunn mentioned the challenges that we've had with RTTDC, which is a great course in terms of teaching like overall management, but suffers from some of the same pitfalls of getting the right people at the table, or at least the ideal people at the table. I'm just curious about how this overlaps with RTDDC. How much is it something that would benefit from doing in parallel? Do you think it covers almost all of the things that RTTDC covers? Is this something that we should be concentrating on instead of? Certainly, we try to incorporate simulation into our RTTDC courses as best we can, but it's still only a small part. So just give me some thoughts on those questions, if you would.
Yeah, that's a great question. I look at it almost more, it's a supplement to RTTDC. It's different because it really focuses on the procedural skills and life-saving maneuvers and stabilization of the patient. And it definitely has more focus on decision-making and actual clinical case-based scenarios, as opposed to focusing on the teamwork as a whole. Now, that being said, I am not an RTTDC instructor. But from what I've gathered with other people, I think there are good things about both programs, but it's still fairly different in that we're really focusing, truly addressing the stabilization of the trauma patient and focusing on procedural competency.
Excellent. Awesome. Thank you so much. Great work.
Thank you all.
Thank you.
All right.
I just wanted to add one more thing, that because I was at the COT national meeting, and I know Dr. Christie mentioned this program at the regional meeting. And so immediately the ACS staff were texting me, we need to meet with this Dr. Mabes, find out about this program, because the rural pillar, although they've been talking about it for 2 years now, it's finally starting to get a little bit of legs under it. And they want to really support rural in 3 ways. One is education, obviously, but PI, because PI is a real challenge in the rural environment. And then what they're calling this like community of support, because they're even talking like they're recognizing that even in level 4s, the AER physician might not even be the best person to be the trauma medical director. It could be like an APP that's like on site based, is not like a, contracted entity or whatever. So they recognize that this whole piece about clinical competency is such a huge portion of it. So Dr. Nathans was, when he approached me specifically about it, I was like, this is going to be something really big. Yeah. So congratulations for that attention. So that's amazing.
Thank you very much. All right, thank you.
Okay, we'll take the morning break now. We'll reconvene in about 10 minutes. It'll be at 11 a.m. And we'll start with the Georgia Committee for Trauma Excellence, Lynn Grant.
Good morning. So as you can see, all of our subcommittees have been very busy within GCTE. Our PI subcommittee continues to work on the PI toolkit, creating guidelines, getting best practices for that. So that will be very instrumental and helpful for all trauma centers once they get that complete. The registry subcommittee, they had 114 Georgia trauma staff attend either the basic or the advanced ICD-10 courses along with the coding books, and they were very thankful for the Trauma Commission for funding that. It was very successful. The subgroup that I mentioned before of the registry containing TPMs, PI coordinators, registrars, they reviewed 5 different registry vendors to see which registry was better fit for Georgia, and unfortunately, none of the registries had everything that trauma centers needed. The one that was the best of all the ones that the 5 they reviewed scored very low. So they will continue to investigate those and report back further. Was there anything else with that? Okay. The education subcommittee, they're continuing to assist in providing TCRN review courses at centers to increase the number of TCRNs within the state. They're leveraging with the RTAC coordinators. They've started attending the education subcommittee meetings to help increase the education for all the regions in the state. And they're continuing to work with the Georgia Trauma Foundation to provide education through rural areas, specifically RTTDDC. And the Injury Prevention Subcommittee continues to work with the LUTC Safe Driving Summits throughout the state, as well as the Shattered Dreams program. The state Stop the Bleed Back to School training blitz they had prior to the school year starting this year. They had over 1,300 attendees, which was very great throughout the state. And they're proceeding once the bingo size expansion is proceeding once the funds are received, and several facilities are ready to launch the new sessions for that. The pediatric subcommittee, they continue to work for their pediatric transfer toolkit, and one of those that they worked on was the pediatric transfer document that mirrors the adult transfer document that was done earlier in the year. This committee, along with the pediatric TMDs and TMD subcommittee, worked on this. And this is it in the packet? Yes. So the GCTE approved this in our meeting in October and November, and the TMDs approved it as well. So this is the indications for pediatric trauma patients requiring transfer to a pediatric trauma center. And then they also created another document. It's a quick reference for assessment, stabilization, and transfer of pediatric trauma patients. They would like to transform into this a trifold for pre-hospital and ED providers and our rural trauma centers. And Dr. Smith would also like to have this available for the rural trauma courses that Dr. Mays is providing throughout the state. And then a third thing that they created was they continue to do the EMS safe transport education, and they created a PowerPoint that will, once approved, will go in the Georgia Trauma Commission background PowerPoint and have this available to all EMS providers throughout the state.
Is that all then? Not very much.
One more thing. Well, that's all to approve for the pediatric.
Silly there, but that's a lot of work, but very impressive. Go ahead.
So the other thing we did back in September, we did a educational needs assessment that was sent out to all GCTE members on what education courses that everyone would need at their center. We had 31 respondents all throughout different level centers, even some non-designated centers throughout Georgia. And the top 3 courses was the optimal course, the topic course, and the injury prevention course. So we would like to propose a 2-year budget for starting for 2027. For year 1, we would like to do the optimal course or the topic. We hadn't really decided yet. One of those courses is the in-person prior to the summer meeting in 26. And then we'll, for whichever course that we don't do that time, we'll do another in-person, maybe Gypstick or somewhere like that. And then the injury prevention course is a virtual 2-day course. And then for year 2, we would like to offer the rural topic as another in-person prerequisite to one of the meetings, and then the trauma registry course. And the trauma registry course will satisfy all the ACS requirements for our trauma registrars. So we ask here on this, you see there, it says $135,000, but we would like to increase that to $145,000 just to add for room and incidentals and logistics.
Can you refresh my memory again, the difference between the optimum and the topic course? I just can't remember.
So both are one-day courses, but Optimal focuses on the gray book and goes through standard by standard and how you meet those standards. And Topic is really just PI process focused. So just really a deep dive into the PI.
And Optimal is really a base for your TMD and TPMs to take together.
So they're really set, I remember that because I've taken the topic and sat through it. And so it really is about PI. So I think both are very important for the trauma centers, plus with Dr. Smith's work and Gina with GQuips, there's so much turnover, keeping people with accurate information and data and understanding. I think that's important. So I think this is very important for the trauma centers to have high quality if we keep on them to do it the right way. So.
Yeah, Lynn, I agree. These courses are paramount in order to run a successful trauma center. My question to you is, so is this an addition to the, is this an additional request or is this, I guess my question is, do we have room in the budget for this is my question. Or is this just a reapproval of money that you already have been approved to have? You know what I'm saying?
I believe the additional request.
So I had asked Lynn, could she put her proposal together now so that we consider it for the next budget? But we do have fireworks fund coming up. We could potentially fund a portion of it. I think if you guys could approve the, courses and the amount, we can figure out where to pull it from. If a portion of it comes from this year, or we can work on that in the finance committee, and a portion of it from next year.
I just want to make sure that, as we get these requests, and they're all fantastic requests, I don't want to downplay the educational need, but I just also don't want to, we have a fixed pie that we're dealing with. And I just want to make sure that we're not, slicing that pie up thinner and thinner for each participant in that pie with additional requests. That's my only concern.
Yeah, I think that's a great concern. I think the one thing that'll help is you don't have to pay for this course yourself. Then sooner or later, I think the college will move forward to probably requiring the topic course as the baseline for PI. And then at least for the injury prevention course, you can demonstrate that you've had your person, whoever that is that's taking on that role in your institution, can show that they've had formal education. So I think it's kind of keeping you from having to, so the readiness can be dedicated to the readiness and not having to fund these other things.
So I'm sorry, I'm kind of slow this morning. So if we use the fireworks, we're not going to degrade any other budget item in the budget by approving this if we so choose to approve this. Is that my understanding?
I think if you go ahead and approve it, if Pete's okay with it, we can take it back to finance and figure out what the options are.
Let's do that.
Yeah.
Okay.
Look at it.
Okay.
A lot of clicking going on here.
Sorry.
No, it's good. So then, if I understand Pete correctly, we'll get a motion to discuss it
Get a
and then
motion
kick
to-
it back to finance to see how we do that. Is that what you're thinking?
I think so.
Okay. So can I get a motion to approve?
Well, we got to wait till Dr. Todd joins us back again.
Okay.
Sorry.
Yeah, the other motion too.
Yeah, we got two motions now. Okay. We'll just we've got a marker in for you. We'll let-
We got a placeholder.
If it's any consolation, I think it's going to get approved as long as we can find the money for it. I think we're all in favor of it. I just want to make sure that we're, being fiduciary responsibly fiduciary. Whatever. Anyway, okay, thank you.
Thank you.
Thank you, Lynn. Okay, we'll move into the rehabilitation committee. Is Dr. Vox giving that report, Liz, and is he on the line?
He wasn't able to make it to this meeting.
What's that?
He's not able to make it to this meeting.
So he's not online either?
No.
Okay, all right, well, we'll move ahead then to the Trauma Administrative Committee report. with Dr. Walker. Is Dr. Walker online?
Yes, sir, I'm here.
Thank you, Dr. Walker. You are on and we can hear you.
Good morning, everyone. Glad to be presenting the Trauma Administrators Committee report. We started off with a review of the FY 2026 funding allocations. Wanted to make sure that the administrators understand particularly the uncompensated care funding and that those are always 3 years in arrears. So our FY 26 allocations are really based on calendar year 2023 dollars. We spent the bulk of our time, however, with Dr. Benji Christie, who presented a very fascinating presentation on readiness planning, lessons from the pandemic and the front line of the Ukraine, where Dr. Christie actually traveled to the Ukraine and learned a lot about the frontline operations in war times and how we might take some of the things that we all experienced during the COVID-19 pandemic and how can we, learn about that, particularly in terms of regional care coordination. I invited Dr. Christie to present to the administrators because, I think we are all aware of the current climate in political climate and whatnot. And we are uniquely situated, of course, as trauma centers across the state. We know that we have various military, Air Force bases and other military installments right here in the state of Georgia. And certainly we are on the coast. We have Savannah as one of the busiest ports in the United States. So I really just appreciate Dr. Christie giving us the presentation, and ultimately I gave a call to action to the administrators to emphasize how important it is for us to think about statewide collaboration, and certainly wanted to raise that to the attention of the Trauma Commission. I think that is something that moving forward would love for us to have, a subcommittee or something so that we can begin to be prepared and truly take the learnings from COVID, utilize them in a productive manner if and when we should have to have a response that we're being told, we should be prepared for. Other than that, we reviewed the 2026 committee dates and those were approved, and that was the bulk of the meeting. Happy to take any questions or comments.
Dr. Walker, it's Dr. Dunn. Thank you very much for your comments, and I'm excited that Dr. Christie was able to speak with the administrators group. I am tied in with the military, and so this whole RMOC or large-scale combat operation and what that's going to mean for the United States and for each individual trauma center in the United States is downright frightening. So I applaud your interest in that, and I would agree with you wholeheartely that we as the state of Georgia need to start thinking about that significantly, because as we all know, our bed capacity is almost non-existent because we're almost all operating at 90 to 100% capacity. So the surge is going to be a huge component of that. So I applaud you guys for starting to think about that, and if I can assist in that, or if we as the Trauma Commission can assist in that, please let us know. But I keep moving forward with that because that's an important concept.
Thank you.
I think from the commission standpoint, I think we could provide directive or request from your group, Dr. Walker. I think we need a plan. I think we need at least some discussion, RMOC development, what things would look like. I really think the commission is not positioned to be able to do that on its own. So I think that really needs to come through your group. So I would like to sort of charge your committee with that task. And when's our next meeting? In February? That's with the holidays, that's probably not achievable with Christmas and Thanksgiving and so on, and people being off. But certainly within sometime in the spring, if you could work with your committee to come up with some solutions or some ideas or some thoughts for the commission to consider. I think that would be very helpful, and we would welcome that, because I think we looked at the amount of expertise on the administrators committee that's spread throughout the state to guide us. And then if we could get some guidance from your committee, the commission could consider, we could go forth with legislative support and maybe obtain funding, or if funding is a need, or a change in legislation if legislation is a need. So I just think there's a lot of things to do, but I think really you're the foundation and the front line. So if you all could work on that, we would appreciate it.
Be happy to. Thank you.
Okay, any other questions for Dr. Walker?
Yeah.
Is it Dr. Vassy?
Yeah,
Dr. Vassy from Northeast Georgia has a question. Go ahead, Dr. Vassy.
Yeah, just a comment and an offer for collaboration. We've been starting these RMOC conversations in the TMD subcommittee and with our GQuip meeting back in the fall at Macon, and that's going to be one of the foci of one of the main agenda items for our in-person TMD committee meeting. So I think there's a lot of challenges. I mean, I think everybody understands the need for RMOCs in a pandemic or a mass casualty situation, but the challenge is finding a duty for those coordination centers on a day-to-day basis so that they're up and ready and running and ready to ramp up when they're needed. And so that's going to take a lot of collaboration and a lot of breakdown of a lot of silos. And so in that regard, I would love to collaborate with the administrators committee and start maybe breaking down some of those barriers.
Well, I'm glad you brought that up, Matt. I think that as you as chair of the Trauma Medical Directors Committee and Dr. Walker as chair of the Administrators Committee, I think if we could get you two together, those committees need to really crosswalk with discussions. And so if I could ask our two leaders, you two, to collaborate through email or calls, whatever, to figure out if you need a smaller work group, maybe 2 or 3 MD directors and 2 or 3 administrators to sort of jumpstart this, that would be great. But I think those two committees need to have a strong line of communication. So thanks for bringing that up. That would be excellent. All right. Any other questions for Dr. Walker? Okay. Thank you, Dr. Walker. Yeah, I think we have a special guest. Could you come forward?
Good morning. Thank you for giving me an opportunity to introduce someone to you. In the past, when you've been here at our meetings, you know, former Commissioner Russell Carlson had been here and met with you guys, as well as Dr. Dean Burke, who at that time was our Chief Medical Officer for DCH. So Commissioner Carlson has moved on, and Dr. Burke actually moved into the commissioner's seat for the Department of Community Health. Wonderful. He and I still touch base a lot, but because he had other duties other than the State Office of Rural Health, he has handed us off to Brian Anino. And so I just wanted to take an opportunity to introduce Brian to all of you, and especially to the board. Brian is the chief. He's a senior attorney, and he's got a lot of titles. I was asking him which one to use. Senior attorney in the commissioner's office.
Mission creep, as they say in the military, I think.
But he also is who we now report to. And so we are introducing him to rural initiatives. And so I'm really excited to introduce him to all of you. He has been a wonderful partner. I've enjoyed reporting to him, and I think we're all going to do great things together. So I appreciate Dr. Burke putting me in Brian's hands. So the State Office of Rural Health has some great support with Brian. So I just wanted to give him a minute to address the group.
Well, thanks, Nita. Thank you, Dr. Ashley. It's great to be with you all today.
Do you want to take the podium?
Great. Thank you.
She's got it mic'd up. So.
I appreciate it. Thank you, Dr. Ashley, members of the board. It's great to be with you all today. Dr. Burke, our commissioner, sends his greetings. He is actually at the NAMD conference today. And big discussions up there are the Rural Health Transformation Project. Georgia submitted its application. It's now online for everyone in Georgia to review. We're very excited about it. CMS has indicated that we're going to be hearing back, that all states will be hearing back by the end of the calendar year. Many great initiatives in that. And this SOAR team is going to be at the forefront of that. So we're very excited. It's great to be with you all today, National Rural Health Day. And I look forward to meeting you all, talking with you and just listening. If I can be of any help at all, please reach out to me. Either catch me here or I'll make sure that you have my email and phone as well. So thank you again. Appreciate the time.
Thank you. Appreciate that.
Thank you.
Okay, looks like Dr. Dunn, you're up with the Trauma Systems Performance Committee.
Thank you, Dr. Ashley. The Systems Performance Committee met recently, and we really talked about four main issues. Our recurring issue is our registry download or coordination from the states, from the trauma centers to the state database, and that continues to be ongoing. We wanted to have a discussion about registry vendors, as I think Lynn Grant had talked about in the GCTE committee. That's going to become, as we move forward, more of a challenge for our state, I think, with our GQIP collaborative. Right now, everyone's on ESO, but with the challenges with ESO, that may become more of a problem to stay with that. But more to follow on that, and there's a lot of, the devil's always in the details when it comes to trauma registries. Our time to definitive care pre-study, which was between Dr. Ashley's shop and my shop, is now complete. We've submitted that data to several academic organizations, and we're waiting to hear back from the Southeast Surgical or whether or not our presentation is going to be accepted for the national meeting. In the meantime, in anticipation of acceptance, we've already started working on both a oral presentation as well as a poster, and the manuscript is in draft form right now and should be complete by the time that meeting rolls around. In anticipation, based on the findings of that meeting, which was briefly in general, time to definitive care in general across all categories did not seem to be a risk factor for mortality, which kind of surprised us, to be quite honest with you. But I think as has been mentioned in the past here, due to our silver tsunami that's occurred with our baby boomers, a lot of our registry volume is flooded with falls from standing. And those people, time to definitive care sometimes doesn't matter regarding their mortality or their eventual outcome. So we've sliced and diced that data multiple ways. And what we did find is that if you are hypotensive, in shock, or requiring blood transfusion, then time to definitive care definitely matters. So I think we can definitely, as a state, push that out to our rural centers or our centers that are transferring patients to level 1 and level 2 centers, that those people really need to have priority when it comes to ambulance transfer. I would say that's a big issue with our state, getting people from point A to point B in a timely fashion. But maybe we can focus on those transports rather than the hip fractures, resulting from fall from standings. But there were some limitations in that study, mostly with sample size. And so we're going to do this as a statewide study now with the help of our GQIP colleagues and our state database. And so we're in the process of putting that together. We're finalizing the IRB right now. The data is really already there, so it just needs to be analyzed. But this analysis, one thing that Dr. Ashley and I both learned, that this requires some high-level statistics, which both Dr. Ashley and I are unable to do. So we have contracted with a statistician out of, I believe, I'm not sure where she's at. Where's she at, Lynn? Shepherd. She's at Shepherd Center. So she's going to be helping us with that data analysis. So really the only holdup right now is our IRB. Once that's formalized, then we can start analyzing that data, and hopefully we'll have something here within the next 3 to 6 months. And finally, based on our systems visit from the American College of Surgeons, one of the things that they urged us to consider doing is developing a statewide dashboard to kind of monitor how the trauma system in the state of Georgia is actually functioning. And so the Systems Committee has come up with some ideas about what that dashboard needs to look like. We're still very in the early phases of what items are going to be involved in that dashboard. But we all agree that it has to really center around system efficiency. Not necessarily so much about outcomes, but how well is the system functioning, and so that we can get a up-to-date, real-time analysis of where our trauma system is and where are our pressure points that we need to work on as a commission to try to improve that efficiency. So hopefully we've already started that collaboration, and hopefully we'll have something to present to you within the next, either at the next commission meeting or certainly by the May meeting. And that concludes my report. Be happy to answer any questions.
Thank you, Dr. Dunn, and I'd like to commend you for your work on that project. It's been a heavy lift and years in the development, and you really sort of jumped on it and really helped get it across the finish line. So thank you, especially pulling the manuscript together and all the work. Your group in Savannah has done a lot of work behind closed doors with other people. But so anyway, thank you for doing that. Okay, we'll move into the Trauma Medical Directors Committee. Dr. Vassie.
Yes, sir. Thank you. Sorry I couldn't be there in person today. Just a couple of items, really brief report this time around. We have not had an in-person meeting since Macon a couple months back. But as Lynn Grant mentioned, we were able to get out the final draft of the PEDS transfer poster to the committee and got unanimous support for that. So that's a really good companion piece to the adult transfer poster that I think will help us with that ditch the door time for those people that it really matters. Good work, and I appreciate the PEDS team that put their heads together to produce that. They did a really good job. Really, the only other thing I wanted to talk about is our next in-person meeting. We kind of touched on some of these topics already, but I do want to. We'll have a meeting at our February GQIP GTC combo meeting at Emory. For the TMD committee, I want to focus on have the RMOC focus. We've started these discussions, but I think it's we've engendered some interest and been able to emphasize this across several of the committees, as Dr. Walker mentioned. But I think it's time that we really start buckling down and putting some nuts and bolts to that. And so I'm going to have one of the centers that is a member of the Alabama Coordination Center do a presentation on how that works. And I'm very interested in finding more about the CPAR RMOC focus from Augusta University. So Crystal, I want to touch base with you and maybe have you come and talk about that. And in addition, based on the conversation a few minutes ago with Dr. Walker, I'd love to have her at our meeting too, and I'll reach out to those two people. But that's what we're working on, and I think I would be happy to take any questions or suggestions from the crowd.
Great work, Matt. And as I told Lynn a while ago when she presented the poster or the information trifo, great work from the committee. So thank you for your help and leadership as well. Any other questions for Dr. Vassie? Okay, I see none. Thank you, Matt.
Dr. Todd is back online, so.
Dr. Todd, well, let's go ahead and get
You want to take up the three, you really have three things, the FY27 preliminary budget, the GCTE education proposal, and then just for good measure, the PEDS resources, the PEDS transfer and stabilization guide assessment and the two assessment tools.
Let's just, you got them there, 1, 2, 3. Let's just take them in order. So just read the.
Okay, so the FY27 preliminary budget. Oh, sorry, FY27 preliminary budget. So you want to take a motion?
Yeah, so can I get up? Well, it's coming from
Right.
Pete and the finance committee. So we don't need a motion then, so we can just discuss it and vote on it. I think we've already discussed it, so I think it's open for vote now. Is that okay, Pete? I'll just call the vote.
Good.
Okay. All right, all those in favor of the preliminary budget we discussed, aye? Aye. Any opposed?
Aye.
Okay, so, we're all good. That passes, whoever's doing the minutes, okay, gotcha. What's the second one there, Liz?
And then the GCTE education proposal.
Okay, we'll need I'll need a motion for that. I want to make a motion.
I'll move it.
Gary's first,
I second it.
Dr. Dunn second. Okay, so it's open for discussion. Any further discussion than we've already had?
Just to clarify, the motion is that we're going to send it back to the budget subcommittee to see if we can find the funds, correct?
I think that's.
The next one. Is that the next motion?
No,
No,
yeah,
this-
if you
this
want
is-
to maybe just add on to the motion that you approve the plan and we'll send back to the finance committee to identify the fund source, whether it's this year or next year.
Yeah.
I agree.
Is that, you got that? Yeah, okay. All good. You're our AI. Try to put that in the right format. Okay, all those in favor, aye?
Aye.
Opposed? Okay, that carries as well. And we got
Okay,
another one,
and then
Liz?
the third one is the PEDS resources that were in your packet, the PEDS transfer guidelines, which is basically mirrors the adult poster that we did. So this is the PEDS version, and then the two supplemental PEDS assessment tools that will be, they won't be posters, but they'll be handouts that can be used for Dr. Mabes' course and in other centers where, you know, PEDS care is dramatically limited.
Okay, can we get a motion to approve those?
So moved.
Gary's first, second. Pete second. Any further discussion? Hearing none, all those in favor, aye? Aye. Any opposed? All right, that carries as well.
Good job. That's it.
Wow, we run the gambit there, okay. All right, so let me get back on track here. So that's Dr. Massey's report. So we'll move into the Georgia Trauma Foundation. Will that be you, Dr.
Yes.
Bleacher?
Yes. So I'm just going to spotlight a few key things that the foundation has been working on recently. The first is the public awareness piece of our mission. It's key to the success of trauma care and something that the foundation focuses on. One of the things that we've been doing is raising the profile of the foundation by appearing in public forums. We actually aired a third episode of the weekly checkup on WSB radio, where we had two trauma survivors with us, one of whom is a remarkable young man who is a Georgia Tech student who on the night of his high school graduation was in an automobile crash and had a traumatic amputation of his dominant arm. And he and one of his classmates had just recently taken the Stop the Bleed course. So one of his classmates who was in the car behind him knew what to do and had a tourniquet in his car and saved his life. And this inspired this young man, his name is Vansh Patel, to become a Stop the Bleed trainer. And he works primarily at Phoebe Putney, where his care was rendered, and he is really an inspiration. That led to another episode where he and I were interviewed for 11 Alive News to feature Stop the Bleed. And I think these higher profile things that shed light on the work that the commission and the foundation are doing is key to fundraising and support from the public. So I think that was very helpful. Also, Ms. Grant in the GCTE mentioned the Back to School Stop the Bleed training blitz, and the foundation was a sponsor for that as well. So that was also an important public relations and public awareness type of event. Also, we are offering grants like we did last year. This year, $100,000 worth of grants, 10 grants of $10,000 each. One grant per region in the state so that we get widespread distribution of this grant money. The period to apply is still open until November 30th. So we'll just encourage anybody who has a project that they would like consideration to be funded to submit the proposal. And that would be on our website, right, Cheryl, to do that. Again, the application period ends November 30th. That would include education, community programs, injury prevention. Really, we don't restrict what we would consider for these grants. So any proposal that would help with the trauma system and further the mission of the foundation would be considered. And then on the table are 2 flyers for Save the Date. On February 24th, we're going to have our annual Trauma Awareness Day at the Capitol, where we get front and center with the legislators and bring awareness to the legislature about the work that the trauma system community does. So there is a QR code there to scan so that you can register for that, because it's important that we know you're coming and have numbers and help with the logistics. The other Save the Date is May the 30th will be the date of our annual gala. It is our largest fundraising endeavor of the year, so it's important that it be successful, and as many people as possible to attend would be great. Every year it's getting better and better and getting larger and more participation, more funds raised. So we want to keep that accelerating. And I think those are the key things. Cheryl, anything you want to add?
One thing.
Okay.
You didn't leave anything out. It's just me adding something. I wanted to, first of all, say thank you to the commission for your support. We appreciate everything that you do to support us as we look to help support the trauma system here in the state. The second thing I'd like to do is to recognize that we have a new employee that many of you all will work with directly. His name is Tyler Bryant. This is Tyler. Tyler has come on board. He's been with us for a month now. A month and a day. He is our community engagement and development specialist. He is going to be working more closely with the RTACs and the different things that we'd like to do regionally to help with trauma care in the state. So when you all get the chance, just welcome him and say hi, introduce yourself. Thanks so much.
You finished on it?
I am.
So I just want to, first of all, great report, and I'm really excited about those grants. That's wonderful. We had discussions almost probably a year ago, maybe longer than that, regarding initiatives or ideas for the Trauma Foundation to start raising money on. And one of those I think you guys agreed to was the Stop the Bleed kits or more tourniquets, right? And so I think our goal was $250,000. And have you made any progress on that, or where are you at?
Yes, thank you for bringing that up. We are investing $100,000 for 2,000 kits to the Stop the Bleed campaign.
Oh, wow, okay. How much money have you guys raised for that? Is it 100,000 or is it?
It's 100,000 that we're investing in that.
Great.
Yes.
And then I guess the follow-up question on is, part of that discussion we had a year ago or so was you guys, it was helpful for you guys to have ideas from us on how, on what to raise money for. Do you still need ideas from the commission to give to the foundation about, you know, these are our 3 top priorities that we would like you guys to try to raise money for, or not? Well, you're still in the process.
We're always open to suggestions. I think what we find to be important is that the commission and the foundation are aligned with what their goals are. We hope to be augmenting, complementing the work of the commission in bolstering the trauma system. And so the foundation doesn't want to be working at cross purposes or in silos and not have a common goal in mind. Right now, I think we've got plenty on board. So I don't think we're actively looking for new suggestions, but we're always welcome to suggestions about goals for fundraising, because the success of fundraising is predicated on having specific goals for how the money will be used. When potential donors are approached, they want to know what their money is going to be used for. So we're always open to suggestions so that we can be more concrete and specific about what we're raising our money for.
Thank you.
And Dr. Dunn, one of our priority projects right now is, in fact, Stop the Bleed. And the $100,000 investment that Dr. Bleacher just mentioned is just our first amount of money that we're putting into the project. We're ready to go. As a matter of fact, we'll be getting some information from Crystal and her team soon on who needs to get those first Stop the Bleed kits. And we are looking to be more on the ground and raise money. I mentioned this is what Tyler will be helping us do, raise the money regionally so that we can go into a region, have an event of some sort, whatever it is we decide would work best there, and have folks from that particular region invest into getting kits for the schools in that part of the state. So it is a priority project, and we will continue to look for different ways to fund that.
Okay. Thank you, John. Cheryl? Oh, thank you, John. Cheryl? Okay. All right, we'll move into OMS&T report. Stacy Smith.
Hello, everybody. We just have a few updates. To start off, we want to congratulate officially Northside Gwinnett Medical Center and Fairview Park Hospital for their ACS verifications. They were verified and redesignated as a level 2 and a level 3 center. Some upcoming things we have is we have opened our schedule for 2026. We already have a couple on the books. So we have consults and designations being scheduled for 2026. So if you need a consult, designation, some centers are doing mock consults to prepare for ACS. We can offer those as well. We mentioned, or someone mentioned earlier about more centers coming in, and we do hope to see in 2026, 4 centers will possibly be added. On the paper, it has 4 centers for level 4, but it's actually 3 centers for level 4 and 1 center as a level 3. And that level 3 will be in Region 9, which is much greatly needed. So hopefully we can get those to be successful, and we're working with those centers. We've been working with them all this year, and hopefully next year they will also be designated and help with our rural centers. Some updates with the registry with OTCPEs. So for fiscal year 25, an update from Marie is the surgical trauma surgeon response and record closure were met by all the centers. The data deliverables are tracked and using ongoing performance evaluations. And then the fiscal year 2024 and fiscal year 2025, the ongoing burn center performance evaluations were also compiled to evaluate their performance and trends. We also are excited that our Office of EMS has a Systems of Care Advisory Council that has representation for trauma, stroke, cardiac, and pediatric specialties. We did vote on our leadership board, and our next meeting is December 9th. So I am thankful for the ones in the trauma centers that are helping us represent the trauma in this council. We also published our 2024 Georgia Trauma Registry Annual Report. The DPH approved this document, and it is on our website. The link is on y'all's packet. We do thank the centers for all the data and registries and imports to be able to prepare this document. The challenges coming up in 2025, ESO data import errors are still being resolved. We're still working with ESO to get those errors resolved. It's been a process. There's supposed to be another update, I think, in the next coming month to see if some of those errors will fall off. Image Trend estimates the 2026 schema file will be available in November, and we will send that out to prepare. They do have that 90 to 180 days to prepare this, and it will have 23 additional elements on that file. As we know, we're anxiously awaiting February now for those level 4 standards. We'd like to see the new ACS standards for level 4. They're, as of TQIP's report, they were gonna release them in February. So we're looking forward to seeing those and seeing how we can move forward with the level 4s and align Georgia's designation with those standards. And if we have to work on any ones, because we were interested about that telehealth, if that was gonna be a mandatory requirement or not. The last two items I have, Office of EMS is still working on that public facing map to identify where blood products are available pre-hospital. It's still in the works, so I'll give more updates when that map gets available and published. And the last item I wanted to highlight with Office of EMS is we've currently, this paper has 5, but we have 6 pediatric readiness centers that have been designated. And at a current ACS visit, one of the centers is a designated level 2 pediatric center, and they highlighted that as a very good strength in their ACS report to be designated with that status. And it gave them, you know, a strength on that standard. So it allowed them to meet and check the pediatric readiness. So if you're interested in that, I have the link on our website so you can get more information, or you can reach out to Sam Sindelar or April Moss if you would be interested in being designated as a pediatric readiness center. And that's all I have. Is there any questions?
Can you list the names of the centers that are going to be level 4s in the one region and level 3, or the one center in level that's going to go to a level 3?
Level 3 is Coffee Regional. They're seeking level 3 designation. The level 4 centers is Colquitt, Satilla, which is in Waycross, and Wellstar Douglas, I think the third one. So those are the 3 that are seeking level 4 status.
That's a big hole down around Waycross. I just happened to look at the map the other day. There's a lot of white areas, so
Yes.
that'd be good.
And Waycross, they wanted to do level 4 their HCA facility. So they were doing level 4 first with hopes to quickly turn that into a level 3. So that would be a level 3 in Waycross and a level 3 in Coffee
That would be
County.
huge for Region 9.
Yeah, that would be, there's a big gap.
Yeah, it's a desert. Yeah.
So good work. Keep them happy.
Growing.
We also had discussions with Piedmont Newton, so to help maybe offset some of that burden at Piedmont Athens, Piedmont Newton is looking.
And there are a few centers that have reached out, but they're not like officially pursuing it. But I think I've had 3 other across the state. And one of them would be in South Georgia as well. But they're just trying to see if their administration is willing to, you know, go forward.
If we can help, let us know. I'm excited about it.
Yeah. Well, I'm excited for Ware County and Coffee County for sure.
Okay. All right, any questions for Stacy? Thank you.
Thanks.
All right, that concludes the committee reports. So any new business from the commission members that came up we don't know about, we need to address? I think stand between lunches. It better be really big. I'm just messing with you. Okay, can I get a motion to adjourn then?
So moved.
Second?
Second.
All right. We stand adjourned. Thank you.